Good morning. तिम्रो सबैजना आएको छैन सुझ 2 मिनेटको रुम है 2 मिनेट्स है 45 मात्र भयो क्लास सकिसक्यो हो र कि बाँकी छ कसैको कुनै ग्रुपको क्लिनिकल क्लास बाँकी छ कि विशाल
हजुर म्याम
क्लिनिकल क्लास सकिसक्यो हो कि कुनै ग्रुपको बाँकी छ क्लिनिकल क्लास
म्याम हाम्रो चाहिँ सक्यो म्याम पेडियाको
हैन अरूहरुको सकिन भए त हामी कसरी क्लास लिनु त फेरि हैन कुनै ग्रुपको बाँकी छ कि भए सोध न एकचोटि है अनि सबैको सक्यो भए चाहिँ हामी स्टार्ट गरौँला नभए एकछिन कुरौँ न को
मैम सबैको सकिसक्यो रहेछ
सकिसक्यो ल स्टार्ट गरौँ है त हामी ओके so today we will discuss about the post-term baby and its problem hey we already discussed about the preterm babies you know what are the problem of the preterm babies some of the disease that are common in the preterm baby detail as well okay so today we will discuss about the post-term baby and at the end we will also discuss about the congenital infections okay so regarding the post-term babies okay what is the definition of post-term baby what do you mean by post-term baby okay so term baby born after 37 completed week up to 42 completed weeks of gestation okay preterm baby means any babies who they were born before 37 completed weeks of gestation okay so post-term baby means if any baby who delivered after 42 complete weeks of gestation no कुनै पनि बच्चा 42 weeks complete भएपछि पनि पछि बल्ल डेलिभरी हुन्छ भने then we call them as a post-term baby okay so preterm baby will also have a problem post-term baby will also have some problem okay but most of the term babies okay if they completed 37 week and up to 42 touch नभएसम्म 42 complete नभएसम्मको बच्चा चाहिँ usually they don't have much problems okay that is a normal babies okay so post-term baby also will have some problem okay so why they will have a post-term baby Okay, so sometimes there may the inaccurate date may be the responsible. Okay, some of the variables, okay, biological variable like some of the hormonal factors, genetic predispositions, okay, is also possible. Okay, if you ask the history to the mother may give history that my previous baby was also delivered after 42 weeks. Okay, if you ask the mothers preterm mothers, they may give history that their previous baby was also preterm. Okay, so in this way you will get there is a genetical predispositions in the certain disease. Okay, okay, so this is a genetical predispositions. Okay, so other than the maternal factors also problem. Okay, like previous prolonged pregnancy. Okay, then all early multipara. Okay, then primiparity. Okay, sometimes primiparity फर्स्ट बेबीहरू चाहिँ के हुन्छ अलिक प्रलङ हुन्छ सेकेन्ड बेबी चाहिँ युजली दे डेलिभर इन 37 38 39 विक्समा हुनु पनि सक्छ ओके एडिबल मेन्स्ट्रुअल साइकल एन्ड ओबेसिटी इफ द मदर इज टु मच अबियस देन दे मे लिड टु प्रलङ प्रेग्नेन्सीहरू हुने चान्स हुन्छ ओके so fetal factors, some of the congenital anomalies. Okay, so congenital anomalies may have a early pregnancy or late हुन पनि सक्छ. Okay, or it sometimes it may be extrauterine pregnancy. Okay, कहिले काहीँ term baby post term भइसक्दा पनि if they are in the extrauterine pregnancy they may have a post term baby. Okay, so some are the placental factors of the postterm baby. Okay, as we know sign and symptoms of the preterm baby. In a preterm baby मा कस्तो हुन्छ भने जस्तै the skin looks very shiny, skin looks very thin, एकदम gelatinous, thin, veins are very prominent हुन्छ भने यो postterm baby मा चाहिँ कस्तो हुन्छ they have a very dry skin. Skin चाहिँ के हुन्छ they looks very dry. Okay, loose and peeling of the skin. Skin चाहिँ के हुन्छ अलिक wrinkleहरू परेको जस्तो देखिन्छ and there is a peeling of the skin will be seen, especially in the palm and sole the skin will be peel off. Okay, so there is a growing of the nail. Pretermहरूमा nailको size हेऱ्यो भने they usually doesn't come beyond the skin surface. तर पोस्ट टर्म बेबीहरूमा चाहिँ के हुन्छ त भनेपछि nail will be very enlarged. पालिराखेको नङ जस्तै अलि enlarged nail will be seen. Okay, so large amount of hair in the head. Okay, प्रिटर्ममा के हुन्छ एकदम फ्युजी उली हेयरहरू हुन्छ भने पोस्ट टर्ममा चाहिँ के हुन्छ large amount of the hair will be seen in the head. Okay, so visible creases on the palm and sole. palm र सोलमा चाहिँ के हुन्छ त सबै क्रिजहरू चाहिँ के हुन्छ एकदमै भिजिबल हुन्छ palm and sole चाहिँ एकदम रिङ्कल हुन्छ र एकदम वेट हुन्छ जसलाई हामी के भन्छौँ हामी पहिला पहिला मान्छेहरू के हुन्छ हातले लुगा धोएपछि प्रलङ टाइमसम्म लुगा धोयो 2-3 आवर्स पछि लुगा धोयो भने चाहिँ के हुन्छ हातमा चाहिँ वेट एन्ड भेरी रिङ्कल हात वासरम्यान ह्यान्ड्स भन्छ हामी सो इन द पोस्ट टर्म बेबी द ह्यान्ड एन्ड सोल हामीले हेऱ्यो भने के हुन्छ इट लुक्स लाइक अ वासरम्यान ह्यान्ड लुगा प्रलङ समयसम्म धोएपछि जुन हातको कलर तिमीले थाहा हुन्छ नि पानी धेरै चलेपछि त्यस्तो खालको चाहिँ पाम एन्ड सोलको स्किनमा चाहिँ त्यस्तो चेन्जेसहरू हामी देख्छौँ पोस्ट टर्म बेबीमा small amount of fat on the body. Green, brown, yellow coloration of the skin. Green, brown, yellow coloration of skin भएको त भनेपछि प्रिटर्ममा चाहिँ के हुन्छ भेरी पिङ्क जिलाटिनस एकदम थिन प्रोमिनेन्ट भेन हुन्छ भने पोस्टर्म बेबीमा चाहिँ के हुन्छ त भनेपछि स्किन चाहिँ के हुन्छ मोस्ट अफ द टाइम द्याट स्किन विल बी स्टेन विथ द म्युकोनियम बिकज एज द टाइम पासेस एज द चाइल्ड बिकम मोर एन्ड मोर मच्योर भएपछि के हुन्छ the peristalsis will start within the intrauterine periods and they will start to pass the meconium. Okay, and then the amniotic fluid itself will stain with the meconium stain, and sometimes the baby may swallow the meconium within the intrauterine periods, or all the body will be stained with the meconium. Okay, so color of the meconium stain in the skin will be seen in case of the postterm baby. Okay, and more alert eyes. The preterm ma ke thyo most of the time they will close the eyes. Eye open गर्ने एकदमै गाह्रो स्टिक भएर एकदमै क्लोज भएर बसिराख्दै थियो almost 24 hour मा 20 to 23 hours they will close the eyes. While in case of the post-term baby, they become very alert, एकदम wide open eyes, looking around चाहिँ हामी देख्छौँ. Okay. Okay, so this you can see, if look, this is a very chubby baby. Okay, some stain जस्तो देखिन्छ, एकदम वेटहरू हेर्दा पनि हामी थाहा पाउँछौँ कि this is the post term baby हैन. You can also look for the genitalia-हरू हेरेर पनि थाहा हुन्छ. You can see the nail हैन, nail will be very large nail-हरू हुन्छ. And you can see palm and sole-मा creases-हरू very prominent, washerman hand you can see. Okay, and in this condition you can also look at the placenta. Okay, most of the time we forget to see the placenta. Okay, यो normal placenta हाम्रो यस्तो रेड यस्तो कलर हुन्छ भनेपछि जब पेशेन्ट the baby become post term हैन, प्रेग्नेन्सीको टर्म उसले क्रस गर्न थाल्छ, you can see the whitish discoloration हैन, सानो सानो the more calcification भइसकेको छ, and this part is also look white. So you can see, so multiple calcification in the placenta will be seen. Okay, placental calcification हुन थालेपछि के हुन्छ त, अब चाहिँ blood circulation gradually decrease हुन थाल्छ र patient, the baby could not grow furthermore, like that in case of the 38 to 42 weeks मा जसरी rapidly grow भइराखेको छ, after 40-41 weeks पछि चाहिँ they start the placental calcification will start भएपछि the child will not grow properly. Okay. Okay, so there are so many problems in the post-term baby. So what are the problem of post-term baby? One of the very common problem is the meconium aspiration syndrome. Okay, so in preterm baby there is very less chance of aspiration of the meconium. So any preterm baby, if you see the baby has a meconium aspiration, then most probably this is a some sort of the infection. Most probably listeria infection is there. Otherwise preterm baby मा के हुन्छ, meconium pass गर्दैन. Okay, because their intestine is not fully mature to start full peristalsis, and stools will not be passed within the uterine cavity. But in case of the post-term baby मा चाहिँ के हुन्छ त भनेपछि they pass the meconium and they will aspirate the meconium during the delivery हुनुभन्दा अगाडि त के हुन्छ, they can swallow and they can go into the stomach and causes irritation of the stomach because the lungs is not fully inflated at that time हैन. तर जब ड्युरिङ द बर्थ प्रोसेसहरूको टाइममा चाहिँ जब लङ इन्फ्लेट हुन थाल्छ हैन, उसको मुखमा भरि म्युकोनियम भएर ट्र्याकियाभरि म्युकोनियम भइराख्न सक्छ इन्ट्रायुट्राइन पिरियडमा. एन्ड वेन दे स्टार्ट क्राइङ ड्युरिङ द डेलिभरी प्रोसेसमा क्राई हुने बित्तिकै चाहिँ दे विल ingestion of the meconium will also occur, and the meconium like they will gradually trickle down in the trachea and they will goes into the lungs. Okay, so will leads to the meconium aspiration. Okay, so what is happening here? So there is a meconium is aspirated. No meconium mukma bhako meconium. Some of the meconium will goes into the stomach and some of the meconium will goes into the lungs. Okay, so what will happen in the lungs? लङ्समा के गर्छ त भनेपछि सम अफ द एयरवे, इफ द म्युकोनियम प्लग एकदम थिन भयो भने युजुअली प्लग गर्दैन. इफ म्युकोनियम प्लग चाहिँ म्युकोनियम चाहिँ के हुन्छ, एकदमै थिक म्युकोनियम स्टेन लाइकरहरू भयो भने they will goes into the trachea and then goes into the main bronchus and then bronchioles-हरुमा जाँदा चाहिँ some of the bronchioles-लाई चाहिँ के गर्छ, they will obstruct. Okay, so lead to the airway obstruction. Airway obstruction भयो भने के हुन्छ, the air could not be flow inside, so definitely the patient will have a hypoxia. But on the other way, what will happen, CO2 could not be come outside, so there will be the respiratory acidosis will occur, then there will be the retention of the carbon dioxide. Okay, so what will happen when the meconium will goes inside? अब meconium के हुन्छ, there is obstruction नभए तापनि they enters up to the alveoli. When they enters into the alveoli, what will happen? They will inhibit the type 2 pneumocytes and they inhibit the surfactant synthesis. Okay, so that can lead to the secondary surfactant deficiency. Primary surfactant deficiency भनेको कहिले हुन्छ त भनेपछि when they are preterm, type 2 pneumocytes is not mature to form the surfactant. Okay, but here there is a type 2 pneumocytes is mature and they are producing surfactant regularly. But what happened, due to the meconium stain liker, this meconium causes the irritations of the type 2 pneumocytes and they transiently inhibits the surfactant synthesis. Okay, so that can also lead to the surfactant deficiency, and leads to the same features like that of the respiratory distress syndrome in case of the preterm baby. Okay. So other what can happens is they can inhale the patchy infiltrations लिएर pulmonary inflammation लिएर आउँछ कुनै ठाउँमा एयरवेलाई obstruction गर्दैन, some other way place they can inflame the muconium will goes inside up to the alveoli and then it can lead to the pneumonitis and there will the patchy infiltration will occur. Anyway, it can cause the airway obstruction, it can cause the surfactant deficiency, it can cause the pulmonary inflammation. All these three pathophysiology will lead ultimately to hypoxia and acidosis. Okay, what will happen if the patient has a prolonged hypoxia? धेरै बेरसम्म हाइपोक्सिया भइराख्यो भने के हुन्छ त भनेपछि ultimately it will lead to the pulmonary hypertension, so which is very difficult to have. This is almost sometimes leads to the irreversible conditions. Okay, so when patient has a severe hypoxia, prolonged hypoxia, for the prolonged durations hypoxia, they can lead to the pulmonary hypertension, so which is very difficult to treat. Okay, so what will happen if you go to the delivery room, you attended the call for the meconium stent likers. Okay, always when you go to the delivery room, you ask the nursing staff whether meconium stent was present in during PV examination. If they say there is no meconium stent liker, you can do the normal care of the newborn. Okay, and if there is a meconium stent is present, then I have to see, you have to wait till this baby is delivered. Okay, so when this baby is delivered, you have to see whether this baby is vigorous or non-vigorous. Okay, vigorous भनेको कस्तो त भनेपछि baby is crying, good heart rate, good respiration and tone, that is vigorous baby. Non-vigorous baby means the baby has heart rate is also less. Okay, and baby tone is also very decreased and the respiration is also not spontaneous. Okay, in this condition we call this is as a non-vigorous baby. If baby is vigorous, you have to do the normal newborn care again. And a suction baby like dry गर्ने, cord clamp गर्ने, you give to the mother and mother will start the breastfeeding. If necessary, you can give a small amount of oxygen as well. But if the baby is non-vigorous, baby did not cry immediately after delivery, and baby has a meconium stent liker, at that time you have to do the intubation and the tracheal suction directly. Okay. So bag and marks is usually contraindicated in meconium stent liker baby because in case of this baby, if you do the bag and marks ventilations, hello. Rami जो क्लास लिया चों एकछिन पछि खुलाने या कौन ले या कौन जो हैं का जो हैं का. Okay, so bag and marks is contraindicated in case of the meconium stent liker because if you do the bag and marks ventilation, the those meconium which are in the trachea and the bronchus that will goes inside the up to the alveoli. Okay, so you should be very careful while doing the bag and marks ventilation in case of the meconium stent liker. Okay, then you shift to the NICU, you do the gastric, you put the NG tube, you have to clean the stomach, you have to wash the stomach, otherwise it will cause this the gastritis and patient will regurgitation, vomiting will occur. Okay, then closely monitoring of the baby. If needed, you will give oxygen. If needed, you can do the ventilation accordingly. Okay. Okay, so how you diagnose the patient with, how you diagnose the meconium aspiration syndrome, okay? The diagnosis is made based on the newborn symptoms of the respiratory distress and presence of the meconium stent liker, okay? हाम्रो WHO ले कसरी define गरेको छ त meconium aspiration syndrome means any baby has a meconium stent liker. Okay, जसको बडीमा म्युकोनियम स्टेन छ अथवा पिभी गर्दा म्युकोनियम स्टेन लाइकर भयो and after delivery if the baby develop respiratory distress then you can diagnose as a meconium aspiration syndrome without even doing the chest x-ray. WHO को अनुसार त गाउँमा त एक्सरे गर्न नपरेको ठाउँमा any baby who has a meconium stem like a developed respiratory distress, your diagnosis will be meconium aspiration syndrome. Okay. So there are a few methods also to confirm your diagnosis. Clinically, the diagnose meconium stem भएको बच्चा अब respiratory distress भयो अथवा retraction start भयो, they have increased respiratory rate, subcostal intercostal retraction or start हुन थाल्यो, means this baby has a now meconium aspiration. So you can do by doing the blood gas analysis. Blood gas analysis ma ke huncha, patient will have a hypoxia, PO2 like कम हुन सक्छ less than 80 and POCO2 more than 50 हुन थाल्यो भने चाहिँ now you can think okay, most probably this baby has a meconium aspiration syndrome. Okay, other way what you can do is the chest x-ray. Okay. So you can see the chest x-ray in this case. Okay, there are multiple patchy opacity is seen. Okay, so this is also the typical cases of the meconium aspiration there, because the meconium is enters within the alveoli and leading to the pneumonitis. So this is a patchy infiltration you can see. Okay, in this x-ray also you can see there is a patchy infiltration here, some ear bronchogram you can see. So this is also the typical x-ray of the meconium aspiration syndrome. Okay, so this is also X-ray of the meconium aspiration syndrome. What is difference between the previous two X-ray? There is no patchy infiltration. There is no features of the pneumonitis. But what you can see, there is a complete white out lungs. Lungs stimulate. There are the compared to these lungs, there is a completely white out opacities. Okay. There is two possibility of the complete whiteout. One is completely, there is a severe grade for RDS, so completely surfactant inhibit garyo and no more surfactant is there, so whiteout lungs भएको हुन सक्छ. Other is there, but in this case, this is because of the collapse. किन त भनेपछि the space between two ribs is very narrow compared to this space. Okay, so this is the collapse of the bilateral long field because of the meconium plug in the main bronchus meconium plug भयो र meconium plug भएपछि air can't come inside and can't go outside. The air within this is completely absorbed, and then there is a completely collapse of the bilateral lung. Okay, and in this X-ray you can see there is a hyperinflation is present. Okay, look, this is flattening of the diaphragm. So right side or left side to diaphragm or almost equally inflated. This is hyperinflation of the lung. So why this is hyperinflated? Because there is a partial obstruction of the bronchus. Bronchus or partial obstruction air can come inside during the inspiration, but during expiration the air can't goes out completely. So there is a retention of the air. There is a obstruction किन भयो meconium plug ले गर्दा obstruction भयो bronchusहरुमा. So air is coming inside, but it can't go out completely. So there is a retention of the air, so leading to the hyperinflations of bilateral lung field. So meconium stent like aspiration ma चाहिँ the different air X-ray can be seen depending upon the condition. So there is a partial obstruction which leads to the bilateral hyperinflation of the lung. This is complete obstructions which leads to the collapse, and this is also partially obstruction. Air mucus is entering inside, which leads to the pneumonitis of the bilateral lungs. Okay. So meconium aspiration syndrome usually occurs in the bilateral lungs and more affected on the right side because right side ma चाहिँ more meconium जाने भयो हामीलाई थाहा छ त्यसको pathophysiology. Okay, so management of meconium aspiration syndrome, how you can manage means main हाम्रो therapy के हो त भनेपछि the patient has a, so oxygen therapy is the main stay of treatment भयो. Okay, so you put the patient warm, radiant warmer राख्यो. You have to give the antibiotic because it will causes the pneumonitis. So you start with the ampicillin and gentamicin if X-ray reveals the pneumonitis. Okay. So depending upon the condition, you can have to put the patient on the ventilator as well. Okay. And sometimes you need to put on the ECMO. Okay. So when patient develops, the patient is desaturating completely. Patient despite of your oxygen treatments, okay, despite of your ventilator management also, If patient is desaturating, mean most probably this patient has a prolonged intrauterine and extrauterine hypoxia, which leads to the persistent pulmonary hypertension. Okay, so in this condition, patient may not be response to your oxygen therapy only. So in those conditions, patient may need high frequency ventilation or ECMO, or patient needs the inhalation nitric oxide. Okay. So differential diagnosis is transient tachypnea of newborn, pneumonia, especially due to the group B streptococcus pneumonia, पनि completely white out lungs भएर present गर्न सक्छ. Same like that of the RDS. होइन, हामीले पहिला पनि भन्यो नि, if patient is preterm and your X-ray suggestive of RDS means it is because of the surfactant deficiency. But patient is term or post-term baby. But when you look at the X-rays, X-ray is completely white out like that of the RDS means most probably this is because of the group B streptococcus. Okay. Okay. Then cyanotic congenital heart disease is another differential diagnosis when term baby is desaturating. Okay. Other is a disorder of the lung development. हामीले अस्ति पढ्यौँ डायफ्रामेटिक हर्नियाले गर्न सक्छ, congenital cystic adenoid malformationsहरूले गर्न सक्छ. Okay, so congenital malformation we have to consider. Okay, so continuous positive airway pressures is one of the modalities of treatment in case of the meconium aspiration syndrome. होइन, हामीले चाहिँ के गर्छौँ त भनेपछि युजुअली हामीले चाहिँ पेशेन्टलाई चाहिँ के हुन्छ बबल सिपामा फर्स्टमा वी गिभ अक्सिजन, होइन, अक्सिजन नेजल प्रोनमा दिन्छौँ, or you can put on the head box up to 8-10 liter. If baby is desaturating, if baby's respiratory distress is increasing, then you can put the baby on the bubble CPAP. In bubble CPAP, while putting the bubble CPAP, we don't go much pressure. Okay, we give 5 to 7 only. Otherwise, we can give up to 9-10 सम्म पनि जान सक्छौँ, होइन. तर यो कन्डिसनमा चाहिँ के हुन्छ त, बिकज अफ द म्युकोनियम स्टेनले गर्दा चाहिँ दे अलरेडी डेभलप द अटोपी, होइन. किनभने पिप डेभलप गर्नु भनेको हामीले त्यो के हुन्छ त भने चाहिँ म्युकोनियमले गर्दा पार्शियल अब्स्ट्रक्सन भइराखेको हुन्छ. द्याट्स वाइ दे आर डेभलपिङ द अटोपी भइराखेको हुन्छ. एयरभित्र आउँछ, बाहिर जाँदैन भनेको मतलब अटोपी इज अलरेडी देयर. ओके, द्याट्स वाइ वी डोन्ट इन्क्रिज मच प्रेसर हियर. ओके. Okay, so the advantage of this non-invasive is CPAP is this is a non-invasive. You don't need to intubate the patients. Okay, you can give. Okay, but sometimes because of the nasal prones, there may be some obstructions, prolonged obstruction गरेर नोजहरू नेक्रोसिसहरू हुन सक्छ. ओके, अहिले कहिलेकाहीँ चाहिँ के हुन्छ एयर लिक ड्यू टु ओभर डिस्टेन्सन. धेरै पिपहरू तिमीले दियो, हामीले भन्यो नि नट मोर देन 7 भन्यो. इफ यु गिभ 9-10 सम्म दियो भने चाहिँ के हुन्छ, देयर विल बी द अटो पिप डेभलप भएर एयर बाहिर निस्किन सक्दैन. रिटेन्सन अफ द एयर विल बी देयर एन्ड देन लिड्स टु द न्युमोथोराक्स. ओके. Okay, so this I already shown you when I give lecture on the respiratory distress syndromes, होइन, RDS मा हामीले के बबल सिपाप हुन्छ. यहाँ वाटर लेभल हामीले डिफाइन गरिदिन्छ. जति तिमीले पिप बढाउनु दिन मन लाग्छ त्यति नै लेभलको वाटर लेभल यु क्यान सो. सो दिस इज द इनलेट एन्ड दिस इज द आउटलेट. ओके, हामीले यहाँबाट प्रेसर यहाँ यसरी दिन्छ. ओके, यो यु क्यान नेजल प्रोनबाट पनि दिन सकिन्छ. यु क्यान बी गिभ विथ द मार्क्स अल्सो. Okay, so another way of giving is the high flow nasal cannula बाट पनि हामीले दिन सक्छौँ. Okay, so another way, if the patient is desaturating, okay, first you start nasal prones, then you went into the head box, and then you give either with the high flow nasal cannula or you give the bubble CPAP. Despite bubble CPAP मा पनि तिम्रो SpO2, तिमीले FiO2 require more than 60% to maintain SpO2 more than 90% SpO2 गर्नलाई 60% भन्दा बढी FiO2 चाहियो भनेको मतलब this is the CPAP failure. Now you have to intubate the patient. Okay, so another way, other way how you guide for the ventilation is the ABG. So when you do the ABG in respiratory distress patient, if PCO2 more than 55 and PO2 is less than 50. Okay, while your FiO2 is more than 50%, to maintain the, and even the saturation is less than 90, means at that time you have to intubate the patient. Okay, So mode of ventilators, you can use the synchronized volume target ventilation as well, or the tidal volume. This volume guarantees ventilator as well. Okay, so these are the different mode of ventilator you can use. At that time, you can increase the pressure up to 20 to 25. Okay, PEEP 5 to 6. Okay, breathing, we usually keep the breath 25 to 30. And if there is a more CO2 retention, then you can increase the respiratory rate. Okay, and the inspiratory time, always you keep 0.3 to 0.4 second, or inspiratory expiratory ratio 1:2. Okay, in this way you can ventilate the patient. So any questions regarding meconium aspiration syndrome? Any questions? Vishal, clear till
No,
now?
ma'am. Yes, ma'am.
Sumina, question ke छ?
No, ma'am.
Clear, sir? If you have any queries, please ask me. Okay. Asmita, any queries? Okay. So now we switch to the transient tachypnea of newborn. Okay. So what do you mean by transient tachypnea of newborn? Name itself suggests it always occurs in the newborn. होइन, न्युबर्न भनेको विदिन 1 विकको बच्चामा हुने रहेछ यो ट्रान्जिएन्ट ट्याकिप्निया. ट्याकिप्निया भनेको उसको रेस्पिरेटरी रेट मोर देन 60 हुने रहेछ. ट्रान्जिएन्ट भनेको कहिले त भनेपछि सर्टेन टाइम, फ्यु आवर्स टु डेजको लागि मात्र हुने रहेछ होइन, कहिले पनि नट मोर देन 5 days. युजुअली इट लास्ट फर फ्यु आवर्स टु डेज होइन, 1 to 2 daysमा चाहिँ यो के हुन्छ आफै सबसाइड हुने रहेछ. ओके. So transient tachypnea of newborns is a benign condition which is self-limiting condition. Okay, even you do not do anything, it will resolve spontaneously by giving few alikati oxygen sinus and it will resolve spontaneously. Okay, it is causing by the delay clearance of the fetal lung fluid after birth. You know, before birth, all the lungs will be filled with the fluid, so which will gradually resolve after delivery. But sometime due to some reason, हामीले अघि पछि कुरा गर्छौँ किन भनेर होइन, कुनै कारणले गर्दा चाहिँ लङ्समा चाहिँ के हुन्छ, फ्लुइड चाहिँ रिजल्भ हुनलाई चाहिँ के हुन्छ, डिले हुन्छ र सो डिले हुने बित्तिकै के हुन्छ, देयर विल नो इफेक्टिभ ग्यास एक्सचेन्ज विल अकर्स होइन. ग्यास कम हुने बित्तिकै, अक्सिजन हाम्रो बडीमा कम हुने बित्तिकै के हुन्छ, द चाइल्ड विल हेभ अ रेस्पिरेटरी डिस्ट्रेस होइन, हो त्यो चाहिँ हुन्छ र ट्याकिप्निया हुने स्टार्ट गर्छ होइन. हामीले फर्स्ट क्लासको हाम्रो आरडिएसको क्लासमा पढ्दा पनि हामीले प्याथोफिजियोलोजी आरआर किन हाई हुन्छ त्यो कुराहरू हामीले कुरा गरिसकेको छ. ओके. Okay, so it is often poses that the diagnostic dilemma in care of the newborn baby with the respiratory distress. कहिलेकाहीँ किन रेस्पिरेटरी डिस्ट्रेस भयो त, ट्रान्जिएन्ट ट्याकिप्निया मात्रै हो कि कन्जेनाइटल निमोनिया हो कि बेबी इज ह्याभिङ रेस्पिरेटरी डिस्ट्रेस भन्ने कुरा चाहिँ हामीले थाहा हुन्छ. बट इफ द बेबी हेज अ सम अदर प्रब्लम वी क्यान आइडेन्टिफाई होइन. तर ट्रान्जिएन्ट ट्याकिप्नियाको बच्चा चाहिँ अदरवाइज लुक्स भेरी हेल्दी, ओन्ली ट्याकिप्निया विल बी प्रेजेन्ट, अदरवाइज बेबी विल बी भेरी एक्टिभ. ओके. सो मोस्ट अफ द टाइम होइन किन यो ट्रान्जिएन्ट ट्याकिप्निया हुन्छ त भन्दा चाहिँ पहिला पहिला चाहिँ के भन्थ्यो त भनेपछि ड्युरिङ डेलिभरी होइन, डेलिभरी हुने टाइममा चाहिँ लङ्सहरू पुरै स्क्विज हुन्थ्यो अनि लङ्सको फ्लुइडहरू सबै निस्किन्थ्यो अनि आफ्टर डेलिभरी चाहिँ लङ्समा फ्लुइड फ्री भएको हुनाले चाहिँ हुन्थ्यो. तर सिएस हुने बेलामा के हुन्छ, त्यो बर्थ क्यानलबाट आउनु पाउँदैन, सो स्क्विजिङ अफ लङ्स विल नट अकर्स देयर, सो लङ्समा चाहिँ एयर वाटर भइरहेको थियो. ओके. सो दिस इज हाउ द प्रिभियस थ्योरी वर्क्स. ओके. तर अहिले चाहिँ नयाँ थ्योरीहरूले के भन्न थालेको छ त भनेपछि passive movements of the sodium through the epithelial channel होइन. हाम्रो चाहिँ के हुन्छ त भनेपछि हाम्रो लङ्समा चाहिँ के हुन्छ त भनेपछि दिस epithelial sodium channels is there होइन, epithelial sodium channels is there. So this sodium channels is responsible for absorptions of the sodiums and the water from lungs to the interstitial space होइन. एउटा चाहिँ स्क्विजिङ मेकानिजम अल्सो प्ले सम रोल होइन, बट इट इज नट बिकज सोली अफ द स्क्विजिङ मेकानिजम ड्युरिङ द बर्थ क्यानल होइन. अर्को के मेकानिजम रहेछ त भनेपछि प्रब्लम त हुन त सिएस भएको बच्चालाई नै बढी हुन्छ, लेस चान्स इन केस अफ द नर्मल डेलिभरी होइन. नर्मल डेलिभरीमा वाट इज द एडभान्टेज अफ डुइङ नर्मल डेलिभरी? नर्मल डेलिभरी इज भेरी पेनफुल Okay, there is lots of stress in the motherलाई एकदम पेन हुन्छ र स्ट्रेस हुन्छ त्यो टाइममा के हुन्छ त भनेपछि मैटरनल इपिनेफ्रिन एन्ड ग्लुकोकर्टिकोइड्स हार्मोन इज एक्टिभेटेड हैन ग्लुकोकर्टिकोइड हार्मोन्सहरु र इपिनेफ्रिनहरु चाहिँ एक्टिभेट हुन्छ जब these hormones are activated what will happen it will stimulate activated the inac receptor channel हैन जुन यो सोडियम च्यानल थियो नि त एपिकल मेम्ब्रेन टाइप 2 न्यूमोसाइट्समा हुने यो च्यानल सोडियम च्यानललाई चाहिँ यसले के गर्छ एक्टिभेट गर्छ र एक्टिभेट हुने बित्तिकै उनीहरूले काम गर्न थाल्छ हैन तर सीएस को भएको मदरमा चाहिँ के डिफरेन्स छ त भने चाहिँ मदर इज इन रिल्याक्स हैन नट सो रिल्याक्स बट स्टिल compared to the normal delivery they are in the relaxed हैन त्यो बेला चाहिँ इपिनेफ्रिन र ग्लुकोकर्टिकोइड्स एक्टिभेसन चाहिँ के हुन्छ एकदमै कम हुन्छ so if there is no activation of glucocorticoids it will not activate the sodium channel हैन सोडियम च्यानल एक्टिभेट हुने थाल्यो र सोडियम एब्जर्ब हुने बित्तिकै वाटरहरु पनि ग्रेजुअली त्यहाँबाट चाहिँ के